Hello and welcome, everyone. My name is Kristen Talbot. I'm the program manager for MAVEN project. Thank you all for joining us today and our friends at Generations Family Health Center for hosting today's session, Atrial Fibrillation, the most common arrhythmia seen in clinical practice with Dr. Charles Schulman. Dr. Schulman was an assistant clinical professor of medicine at Harvard Medical School from 1988 until 2016. He is currently a corresponding member of the faculty of Harvard Medical School and a senior physician at the Beth Israel Deaconess Medical Center in Boston. In addition, he has been practicing non-invasive cardiology since 1970. Dr. Schulman's scientific articles and abstracts have appeared in the New England Journal of Medicine, Circulation, the American Journal of Cardiology, and the British Heart Journal. And we are so very lucky to have him as one of our MAVEN project volunteers. So Dr. Schulman, when you're ready, please begin.
Okay, well, thank you, Kristen, and good morning, everybody. It's nice to be here and to present my talk on atrial fibrillation. Atrial fibrillation is the commonest arrhythmia seen in clinical practice. It's the commonest arrhythmia that you see in primary care practice. It's the commonest arrhythmia that general cardiologists see outpatient and inpatient. And it's the commonest arrhythmia that the electrophysiologists see. So it is terribly common and also terribly important. With that, we have two disclosure slides. No one involved in this project has any disclosures or any conflicts of interest. The project is accredited by MAVEN, and you'll get one category 1 hour of credit. So what we'd like to do is a number of things during this talk. Start with a general approach to arrhythmias, review the history and the risk factors for atrial fibrillation, implement the ABCs of AFib management, and review the new guidelines for atrial fibrillation that ACC/AHA has just come out with last month, and to make sure that appropriate anticoagulation is prescribed. So this is my approach to arrhythmias. Number 1, look at the patient. You can never, you can always start there by looking at the patient. But in this case, what I mean is two things. One is the patient hemodynamically stable? If not, you may need to cardioverse the patient no matter what the rhythm is. If the patient is stable, then you have time to do a 12-lead ECG and to examine it, et cetera, et cetera. In addition, does the patient have structural heart disease? Does he or she have valve disease? What is the ejection fraction? Because that will impact your treatment. Second, look at the EKG or the ECG. And on the right-hand side of the slide is a systemic approach to arrhythmia interpretation with 5 key parameters. Watch your P's and Q's and the 3 R's. So P, are there P waves? Or if no clear P waves, are there signs of atrial activity such as fibrillatory waves or flutter waves? Is the QRS wide or not? That would have importance in terms of your differential diagnosis. And the 3 R's are rate, regularity, is it regular or not regular, and are they related? Is there a specific relationship between P waves and QRS complexes, between atrial and ventricular activity? Third, look for and treat precipitating or reversible factors. Electrolyte imbalance, ischemia, drugs, hypoxemia, hyperthyroidism, and so forth. Finally, Finally, treat the arrhythmia if necessary. Some arrhythmias don't require treatment, but if they do, drugs, devices, and surgery are all potential treatments. The scope of the problem is considerable. 50 million people worldwide are estimated to have AFib, 5.6 million in the United States. The prevalence and incidence is predicted to double between 2010 and 2030. The overall lifetime risk is 30 to 40% in white individuals and 20% in African American and individuals, and the risk rises with age. It results in considerable death, considerable other endpoints and cardiovascular events, and costs considerable amounts of money. This is one of my favorite slides, actually, because it illustrates very clearly the difference between sinus rhythm and atrial fibrillation. So with sinus rhythm, the impulse starts at the SA node, travels to the AV node, and then through the His-Purkinje system to stimulate the ventricles, resulting in a standard electrocardiogram with a P wave representing atrial activity, the QRS representing ventricular activity, and ST segment and T wave representing recovery. With atrial fibrillation, there are upwards of 350 per minute of the wavelets of electrical activity beginning in the left atrium, bombarding the AV node, which cannot transmit all of them. So the AV, there is variable penetration, or put another way, variable block in the region of the AV node before the impulses are transmitted to the ventricle. If there's more penetration, there's more refractoriness between beats. If there's less penetration, there's less refractoriness per beat. And this results in an irregular rhythm. Here's a 65-year-old woman who has diabetes, hypertension, and presents with shortness of breath and edema. She has a rapid, irregular, notice you can see the irregularity, supraventricular rhythm, right? QRS complexes are narrow. And this, you can guess with pretty high, a pretty high percentage of surety that this is atrial fibrillation. Now, here's a MAVEN e-consult that I received some time ago. A 54-year-old asymptomatic man who has hypertension was found to have atrial fibrillation. Notice irregular, no visible P waves. Okay, so this is atrial fibrillation. He has a CHADS-VAS score of 1, and the question is, should he be anticoagulated or should we prescribe aspirin? And I'll answer those questions after a further discussion. These are smartwatch recordings. When the Apple Watch was the only smartwatch that was capable of doing this, I called it Apple Watch recordings, but subsequently other brands have been developed so that we can't advertise one brand over another. So this is a smartwatch recording, and the smartwatch says that this person has atrial fibrillation at a rate of 118 beats per minute. And as you look at the tracing, it's a pretty good tracing. It's a pretty clear tracing. what you do with your smartwatch is you make the recording, and then you can export it as a PDF to your phone or to your email and print it out and have a look. This is me. Sinus rhythm, clearly sinus rhythm. I have a single premature complex shown here. This is a patient who called me up in a panic because her smartwatch said that she had atrial fibrillation. But in fact, she doesn't. You can see baseline that's clear enough with P waves before the QRSs with frequent atrial ectopy. So this is not AFib, and I was able to reassure her that she did not have atrial fibrillation. Here's a 64-year-old woman who complained of palpitations. She has a rapid, irregular rhythm, supraventricular. This is obviously, again, atrial fibrillation. And the question is, what endocrine disorder is this most consistent with? Hypothyroidism, hyperparathyroidism, Cushing's disease, Addison's disease, or hyperthyroidism? The answer is hyperthyroidism, and which is one of the reasons that if you see a patient with atrial fibrillation, you should obtain a TSH. Here's another MAVEN e-consult that I received. 71-year-old man who had atrial fibrillation for a year. Okay, so it's persistent but asymptomatic. Okay, he feels fine and has no exercise limitation. He has hypertension, hyperlipidemia, normal blood pressure on treatment, heart rate in the 70s, exam is normal, laboratory data is normal. His CHA2DS2-VASc score is 2. He gets 1 for his age and 1 for hypertension. He's currently taking rivaroxaban, atorvastatin, and diltiazem. And the cardiac, the primary care practitioner who sent the consult to me said that a cardiologist said he would be a great candidate for cardioversion or for ablation. She wanted my opinion about that, and I'll give you my opinion about that after we get some more data. Consider atrial fibrillation as a continuum of disease. That is, in the beginning, there are episodes, short episodes, becoming longer episodes, becoming permanent AFib. At least in part, or because of remodeling that occurs in the left atrium. The left atrium becomes enlarged, it becomes scarred, leading to reentry circuits. So there is both structural and electrical remodeling of the atrium as time goes on. Early in the course of atrial fibrillation, AFib triggers are more important. Later in the course of atrial fibrillation, the AF substrate is important. Which leads us to the new guideline, published in January of this year, the 2023 ACC-AHA-ACCP Heart Rate Society guideline for the diagnosis and management of atrial fibrillation. So many of the slides that I'm going to show you come from that guideline. The guidelines use the following scheme for recommendation. This is actually the scheme in all of the cardiology guidelines. I don't know the other guidelines, so I can't tell you if it's the same. But certainly in cardiology, the guideline classification scheme looks like this. A class 1 indication is a strong indication. The benefit is much greater than the risk, and the test or procedure or treatment is recommended. A class 2A recommendation is a moderately strong recommendation. The benefit is greater than the risk, and you can think of it as being reasonable, can be useful or effective or beneficial. A class 2B recommendation is a much weaker recommendation. Yes, the benefit is greater than the risk, and so it may be reasonable, or it might be considered, in the context of the patient. Class 3 are either no benefit or harmful, and so are not recommended, or are recommended against. Turning to the risk factors associated with atrial fibrillation, there are a number of them shown here. There are some non-reversible ones, including certain risk genotypes, older age, family history, and reversible ones. AFib is fairly common after cardiac surgery, or it's common enough with valvular heart disease or coronary disease. The starred risk factors are purposely starred that way because treating these treats the AFib, sleep apnea, diabetes, hypertension, and obesity. So the guidelines suggest that we think about what they call primary prevention. Okay, these are people who do not have atrial fibrillation, but may have hypertension, diabetes, obesity, lack of physical activity, sedentary lifestyles, too much alcohol consumption, and cigarette smoking. And so the guidelines recommend it. You don't need a guideline to recommend that you treat these, but in the context of AFib, treating these will hopefully prevent the formation of atrial fibrillation. Now, the guidelines recommend what are called AFib stages. Okay, so the first stage would be at risk. This would be so-called primary prevention, treating modifiable risk factors. The second stage would be something called pre-AFib. That would mean not only with risk factors, but with evidence of structural or electrical findings that predispose a patient to AFib. Left atrial enlargement, either on an echocardiogram or on the ECG. Frequent atrial ectopy, short bursts of atrial tachycardia, atrial flutter. Then there are the people who actually have AFib. That would be this third stage. Okay, it may be paroxysmal, that is intermittent and terminating within a week, spontaneously. Persistent, lasting for more than a week and not terminating spontaneously, requiring intervention. Long-standing persistent, AFib that's continuous for a month or more, for a year or more. Patients who have had an ablation and do not have AFib afterward. And then permanent AFib is where both the patient and the doctor agree that no further attempts at rhythm control will take place. At all of these stages, treatment of modifiable risk factors is important, and then ongoing monitoring as appropriate for AFib burden. AFib burden is the percentage of time that you are actually in AFib. We get figures for AFib burden on the long-term ambulatory ECG monitoring systems. These are the pillars for AFib management. The 4A's, access to all aspects of care for everyone, for all, because they wanted to make it an A, and SOS, stroke risk assessment and treatment, optimize all modifiable risk factors, and symptom management, managing AFib burden with either rhythm control strategies or rate control strategies with shared decision making and treating risk factors as listed down here. So when a patient presents with atrial fibrillation, you want to know what the symptoms are: palpitations, chest pain, shortness of breath, fatigue. You want to know what the circumstances are. Is it postoperative? Is it related to volume overload and heart failure? Is it have episodes of AFib started in the middle of the night? If so, consider sleep apnea as one of the etiologies. Are there autonomic triggers, and is there significant alcohol ingestion? We've already think about the pattern, which we've already talked about. What tests should be done? As I said earlier, a TSH to rule out hyperthyroidism, and an echo to assess LV, left ventricular function, and to identify structural heart disease. And consider testing for sleep apnea. Assess the risk for stroke. That should be done early and actually on a almost yearly basis. You do not need to evaluate a person with paroxysmal atrial fibrillation for ischemia every time he develops an episode of atrial fibrillation. The patient who shows up in your office with an irregular rhythm and as asymptomatic, for example, you don't need to hospitalize that patient looking for ischemia. Even if the patient is symptomatic with palpitations, you don't need to evaluate the patient for ischemia. You may need to send the patient to the hospital because he's in heart failure. That's different. Don't need to restrict moderate caffeine intake, and don't need to restrict mild alcohol intake. And so the considerations in the management of AFib are, first for rate control, right? Both acutely, certainly. Then stroke prevention, right? At the same time, treating the risk factors, and then developing a long-term strategy for reducing symptoms, either maintaining sinus rhythm or managing continued atrial fibrillation. So let's turn to stroke prevention. There are two means of stroke prevention. What we're all familiar with are pharmacologic strokes, pharmacologic measures, excuse me, which reduce the stroke risk by 2/3 anyway, with either warfarin or the direct oral anticoagulants, dabigatran, rivaroxaban, apixaban, edoxaban. Aspirin and or clopidogrel are not effective. They have been proven in randomized studies not to be effective, and yet carry the same bleeding risk as anticoagulation. So aspirin does not count. Non-pharmacologic measures may be useful at the time of surgery, left atrial appendectomy, or the Watchman device, which is a left atrial appendage closure device. This would be most useful for a patient who has a fib, who may or may not have had emboli, but who has a high bleeding risk, or who has bled with a resultant anemia, and so anticoagulation would remain relatively contraindicated in such a patient. In order to determine stroke risk, we use the CHADS-VASc score. In order to determine bleeding risk, we use the has-bled scheme, although this has been downplayed by the recent guidelines, and I'll tell you why in just a minute. So the CHADS-VASc score gives 1 point for heart failure, 1 point for hypertension, 1 point for diabetes, vascular disease, age between 65 and 74, and female sex, and 2 points for age over 75, and 2 points for previous stroke, TIA, or thromboembolism. A CHADS-VASc score of 2 correlates approximately with a 2% risk of stroke per year. CHADS-VASc score of 1 correlates roughly with a 1% risk. Now, bleeding risk is indeed associated with these findings, but the problem is that some of the items on the has-bled score, elderly patients and hypertension and stroke, are also on the risk score, on the CHADS-VASc risk score. So it's somewhat less useful. Hypertension, incidentally, was in the has-bled score was a blood pressure over 160 systolic. When considering antithrombotic therapy in atrial fibrillation, the guidelines can give a class 1 recommendation to an annual risk stratification using the CHADS-VASc score. Okay, there are some. Before we get to that, though, I just want to review some long-term contraindications. Right. So if you have severe bleeding due to a non-reversible cause, that would be a contraindication to anticoagulation. Likewise, intracranial bleeding or aneurysms due to a non-reversible cause are contraindications. And serious bleeding related to recurrent falls is somewhat controversial. Elderly people are prone to fall, but somebody figured out that it would take 295 falls in order to outweigh the benefit of anticoagulation. So it would have to really be associated with serious bleeding rather than not. Long-term anticoagulation is still reasonable if the bleeding source is treatable or is due to isolated trauma or to a procedural complication. So, to the annual risk stratification, if the risk, so the guidelines suggest that if the risk threshold for anticoagulation is, if the risk is greater than 2% per year, anticoagulation is recommended with a class 1 indication. 2% would roughly equate to a CHADS-VASc score of 2. It's reasonable, right? Reasonable, class 2A. If the CHA2DS2-VASc score is if the risk is between 1% and 2%, or with a CHA2DS2-VASc score of 1. In terms of choice, DOACs, the direct oral anticoagulants, are preferred with two exceptions, two important exceptions: mitral stenosis and patients who have mechanical heart valve, because those patients should receive warfarin, period. Aspirin, as I said, is not recommended, right? Class 3. So some of the modifiable risk factors for bleeding risk are high hypertension, so control blood pressure, people who have labile INRs on warfarin. It's where the INR is 1.5 one time and 4.5 the next time. Those patients, you should really think strongly about that person taking a direct oral anticoagulant, unless they have a mechanical heart valve. Medications predisposing to bleeding, like NSAIDs. Okay, now this is the stealth bleeding risk, because people take ibuprofen, naproxen, and/or their brands without telling you. So you have to really emphasize that though they should not be used. Tylenol is useful, or people medication which predisposes to bleeding, like antiplatelet drugs, and we do have people with coronary disease who are also on aspirin, and post stent or PCI. There are patients on both aspirin, clopidogrel, or one of the other antiplatelet agents, and aspirin, and that is a higher risk for bleeding. Excessive alcohol is a risk for bleeding. And this is a comparison. This is comparison of warfarin, or vitamin K antagonism, and the direct oral anticoagulants. The half-life of warfarin is days. The half-life of the DOACs is somewhere between 5 and 17 hours. For warfarin, you need frequent blood tests, and there are dietary restrictions. But there's once daily dosing, and it's cheap. For the direct oral anticoagulants, there's no testing, no dietary restrictions. They're either once daily or twice daily in the case of apixaban dosing. It's been shown multiple times that there's less bleeding than warfarin. You have to adjust the dose with renal impairment. I'm going to talk about that in a minute. And remember, it's contraindicated in patients with mechanical heart valves and moderate to severe mitral stenosis. And they are expensive, so cost becomes a problem. Or cost may become a problem. Not does, but it may become a problem depending on insurance. The reason that the recommended target INR is between 2 and 3 is illustrated here, because when the INR is less than 2, the stroke risk rises, and when INR is greater than 3.5, the bleeding risk rises. So this shows some of the dose adjustments for patients who have reduced renal function. For rivaroxaban, edoxaban, and dabigatran, when the creatinine clearance or the eGFR is less than 50, you should reduce the dose. With apixaban, The criteria are for two of the following. Okay, this comes from the study where apixaban was approved, so it's somewhat arbitrary in that regard. It was one of the criteria that the investigators developed. If you have a patient over the age of 80 whose serum creatinine is 1.5 or greater, reduce the dose to 2.5 milligrams twice a day instead of 5 milligrams twice a day. Or if the patient is very slight and weighs less than 60 kilograms. But if that's not the case, use full dose apixaban. So somebody who's over the age of 80 whose creatinine is 1.2, 1.3, use full dose anticoagulation. A few comments, pearls about antithrombotic prophylaxis. The elderly are at greatest risk of both stroke and bleeding, but the risk-benefit ratio clearly favors anticoagulation. The stroke risk of intermittent or paroxysmal AFib is the same as chronic AFib. That's why we anticoagulate these folks. AFib ablation and or the use of antiarrhythmic drugs does not allow discontinuation of anticoagulation. There is a risk of clot formation with atrial flutter, and again, aspirin doesn't count. So these are a couple of scenarios to consider whether we should anticoagulate these people. Here's an 88-year-old asymptomatic woman with an irregular pulse. Her ECG shows AF. Her creatinine was, I think, 1.3. Anticoagulate? Yes. DOAC? Yes. At full dose. 77-year-old woman with rheumatic heart disease, status post a tissue valve, not mechanical valve, for severe MS with permanent AF. This is one of those situations where you should use warfarin. A 50-year-old man presented with a left hemiparesis was found to have paroxysmal AFib on the Zeo patch, long-term ECG monitor. This person should be anticoagulated, preferably with a direct oral anticoagulant. This 74-year-old man who had a cabbage 3 years ago and was found to have AFib a month later, so it wasn't due to the cabbage, okay, was treated with rivaroxaban, but had significant hematuria and a falling H&H, and he wound up with a Watchman device. And the last is a 43-year-old woman, status post provoked PE, thought to be due to birth control pills, who had a short episode of AFib. So this person has a CHA2DS2-VASc of 0. And should you anticoagulate this person? Probably not. Okay, back to our 54-year-old asymptomatic man with hypertension whose CHA2DS2-VASc score is 1. Well, certainly he shouldn't receive aspirin. I would anticoagulate it. I would lean toward anticoagulation, and recent articles have also recommended anticoagulation with a CHA2DS2-VASc score of 1. Turning to rate control and rhythm control. You have to address rate control in AFib with a rapid ventricular response acutely. Okay, if the patient is not hemodynamically stable, cardioversion. If the patient is hemodynamically stable but does not have heart failure, beta blockers, verapamil or diltiazem have a class 1 indication. If the patient has decompensated heart failure, amiodarone is preferred, although with a class 2B indication. And verapamil and diltiazem are contraindicated because they are myocardial depressant. For long-term rate control, it depends on left ventricular ejection fraction. Okay. If the ejection fraction is less than 40, stay away from diltiazem and verapamil. Beta blockers have the class 1 indication. So beta blockers are the rate slowing drugs that you should use. Digoxin is a distant second. If the left ventricular ejection fraction is greater than 40, however, either beta blockers or calcium channel blockers can be used with digoxin, a distant third. Okay. What about cardioversion? The indications are hemodynamic instability, as I've already said. A patient who's symptomatic with their AFib, where there's a potentially reversible cause. And if this is the first episode, so the philosophical question is, does everybody deserve a chance at sinus rhythm? Or should you wait a while and see if it reverts by itself? Reasons not to cardiovert might be asymptomatic or minimally symptomatic, especially in the older age group, or if there's a low likelihood of successful cardioversion or maintenance of sinus rhythm, for example, with a large left atrium seen on echo. There are risks of thromboembolism with DC cardioversion, and so if you need to cardiovert, if you are not planning to cardiovert immediately, the patient should be treated adequately with anticoagulation for a month prior to the cardioversion. If you need to, if there's an immediate need, perform a transesophageal echo to make sure that there's no left atrial clot. Okay, subsequent oral anticoagulation depends on the Chance-Vest score. As an initial strategy, rate control for most asymptomatic patients, again, strongly preferred in the elderly with minor symptoms. Rhythm control strategies are favored for younger age, first episode. Tachycardia-mediated cardiomyopathy, and I'm going to show you an example of that. If rate control is difficult to achieve, or if there was a temporary event, or if it's the patient's choice. And we're going to talk more about that in a little bit. The goals of rhythm control therapy in atrial fibrillation, and this comes from the guidelines, for recent AFib diagnosis, that is less than a year, the rhythm control strategy can be useful to reduce hospitalization, stroke, and mortality with a 2A indication. If there is reduced left ventricular function and persistent AF, rhythm control is recommended with a class 1 indication. If there is AFib and heart failure, rhythm control can be useful for improving symptoms, outcomes, cardiovascular outcomes in patients with heart failure. In atrial fibrillation, you lose the atrial kick, which may have, particularly in heart failure with preserved ejection fraction, more hemodynamic consequences than with a reduced ejection fraction. If there's symptomatic AFib, rhythm control can be, people will feel much better in sinus rhythm. Okay, the drugs for the maintenance of sinus rhythm depend on function. So if the patient has normal LV function, no prior MI, and no significant structural heart disease, you have a choice. Often we use flecainide first, and amiodarone second. If there's prior MI or significant structural heart disease, including a low ejection fraction, amiodarone or dofetilide are the drugs of choice. Dofetilide is like amiodarone. It's a class 3 antiarrhythmic with fewer side effects, except that it requires a 3-day hospitalization in order to make sure that you don't have the side effect of torsade de pointes. Sotalol would be a second choice. Flecainide and propafenone are contraindicated because they are myocardial depressant. So, given a patient with atrial fibrillation, treat reversible causes, select an anticoagulation therapy, and then, if the patient has paroxysmal AFib and no bothersome symptoms, follow it. If the patient has bothersome symptoms, think about, rate control or rhythm control. If the patient has persistent AFib, think about rate control. If the symptoms resolve, if their symptoms resolve, no, routine follow-up. The symptoms don't resolve, adopt a rhythm control strategy, either with drugs or with catheter ablation. So we'll see. This is an example of tachycardia-induced cardiomyopathy. The patient was hospitalized with AFib and acute decompensated heart failure and an ejection fraction on an echo of 24%. Patient was cardioverted to sinus rhythm, and a repeat echo was much better. AF recurred a month later, or less than a month later. Well, yeah, a month later. And amiodarone was started at that point. An ejection fraction, still in AFib, was basically the same. In October of that year, after being fully loaded with amiodarone, patient was cardioverted to sinus rhythm, in which she remained for the next 2 months, and her echo then showed an ejection fraction of 61%. So this is tachycardia-induced cardiomyopathy. This is ablation, percutaneous pulmonary vein isolation, or PVI. Catheter is introduced into the vena cava, crossed over the left atrial septum to the pulmonary veins, where the ablations take place, either in a circular pattern, but there are other patterns, box isolation, touching rings, single ring, etc. The optimal candidates are people who are symptomatic, who've failed at least one drug, but ablation is recommended earlier and earlier now, and for some people, it's a patient discussion and a patient choice. It's 75% effective, although some people require a second procedure. And there's a 50% likelihood of detectable AFib at 1 year, but the AFib burden is much less. The risks are quite low. These are 2 studies that point the way toward earlier rhythm control having benefit. So in the East AFNet-4 study, the 2,800 patients with a mean age of 80 had a 21% reduction in the primary outcome, which was cardiovascular death, CVA, ACS, and heart failure hospitalizations. So this is one of the points favoring early rhythm control. This is a comparison of ablation and drug therapy, showing that ablation led to a much reduced incidence of first recurrent AFib episode. So, and a number of studies where ablation was compared to antiarrhythmic drugs, ablation always comes out better. Most people feel better after ablation. Most have a reduction in the burden of the AFib. See, they may not have none, but they have a reduction in the burden, and that's why you must continue anticoagulation. Although 30% of patients remain on an antiarrhythmic drug, it is not curative. As I've already said, that it hasn't become more effective, but the operators are performing so many of them that they're becoming more skilled. At the Israel Deaconess Medical Center in Boston, there are upwards of 600 of these things performed every year. So back to our patient with AFib for a year, asymptomatic AFib for a year. He would be a great candidate for cardioversion. No, he wouldn't. On the other hand, ablation would be a consideration, again, after a discussion with him. Is that what he would, you can present the options. He can stay in AFib or can try an ablation. This is atrial flutter. The issues for atrial flutter, notice